Hello, did you know that every 10 seconds worldwide, there are about 46 births and 18 deaths? This means that every week a net 1.7 million people are born into the world. Staggering, isn't it? Data from the Population Council showed that in 2012, out of the over 200 million conceptions that year, 40% of these conceptions were unintended. Some families may not mind this at all, but for teenagers, it can mean a significant change in quality of life and prospects. Thankfully, in the UK, the statistics suggest that the number of teenage pregnancies is continuing to fall. This may suggest that there is better access to effective contraception at an early age, and knowledge about sexual health has also increased remarkably. This includes delaying the age of first sex, sexual education in schools, and support for parents to discuss relationships and sexual health. Primary care providers including GP surgeries, sexual health clinics and pharmacies are active in this area by providing contraception counselling consultations and practical skills in fitting some contraceptive devices. Up to 2015, GPs' quality outcome framework indicators discuss long-acting reversible contraceptive alternatives with female patients when they were prescribed contraceptive patches or pills, or those seeking emergency contraception. There was a consensus that its high achievement rates suggested it was now part of good practice, and it did not require incentivizing. This is a good quality improvement activity for GP trainees to investigate and ensure continued best practice for patients in the practice. One reason to choose a long-acting reversible contraceptive is the sheer simplicity of the method. In this video, we will run through a general knowledge framework around contraception with the hope that you will find it easier to talk about in a clinical setting. You should expect sensitivity around the subject of sexual health and contraception. Many women have had varied experience with the knowledge or use of different contraceptive methods, and each consultation should afford the patient time to discuss their ideas, concerns, and expectations. Aside from the obvious reason to request contraception, which is to prevent an unwanted pregnancy, there are other possible reasons to consider using a contraceptive method. Prevention of sexually transmitted infection. Some barrier methods, like condoms, can offer protection against some STI. Another common reason is for managing heavy, irregular, or painful periods that impact a patient's quality of life. These symptoms are reported in various gynecological diagnoses like endometriosis, adenomyosis, fibroids, menorrhagia, premenstrual syndrome, etc. The hormonal methods can help with this. The impact on quality of life is very important to consider when taking a history before deciding on using a contraceptive method, because this is the backdrop on which to relate risk factors and the success or failure of each method. All consultations are confidential and especially relevant when working with minors. If you are under 16 years old, your GP will check Gillick's competency and apply Fraser guidelines when exploring contraceptive advice and treatment without parental consent. To assess Gillick's competency, the clinician must establish there is no coercion, pressure, or influence from someone else on the minor. We can use Gillick's competency for other scenarios that require decision-making. Fundamentally, the child should be able to show understanding of the information given, risks and benefits as regards contraceptive choice, and be able to explain their rationale around their reasoning and decision-making. The Fraser guidelines offer protection for the child under 16 years by ensuring the practitioner is protected should the clinician decide to offer contraception to the minor. It states that a minor will be able to consent to treatment if they demonstrate sufficient understanding and intelligence to understand fully what is proposed without parental approval. How is the effectiveness of any method of contraception commonly reported? Usually, it is reported as the rate of unintended pregnancy per year if 100 women used that method. The research results are very variable. It is more variable if you consider what you will call a perfect use versus a typical use. A perfect use means that the method was used correctly and consistently during every act of intercourse. A typical use means there was some incorrect use or non-use on one or more occasions. However, if we want to share the failure rate with patients, it's recommended to use the typical use figures, as this may be closer to real-life failure rate compared to perfect use. For example, if 100 women used a combined contraceptive pill typically for 1 year, there is a 9 in 100 chance of unintended pregnancy during that year of use. What is the common mechanism of action of the various contraceptive methods? Barrier methods like condoms, cervical caps, or diaphragms prevent the passage of sperm into the fallopian tubes of the woman. The physical barrier is at the level of the penis or the level of the cervix. The hormonal methods, pills, implants, and injectables, work by either preventing ovulation in the woman with or without thickening the cervical mucus to prevent penetration of sperm. This leads to the failure of fertilization. The copper intrauterine device and hormonal intrauterine system both work by blocking fertilization. This is achieved by creating an inflammatory fluid in the female genital tract that will prevent the safe passage of sperm. Copper IUD can create this inflammatory fluid quicker in the hormonal intrauterine system, which is why the former is used in emergency contraception. The progesterone-releasing IUS markedly impairs sperm penetrability of the cervix and uterine fluids, can stop ovulation, and they also have anti-implantation effects. The copper in the copper IUD is toxic to sperm and OVA. These actions make both effective, long-acting, reversible methods of contraception. As previously mentioned, a copper IUD is more effective than hormonal methods of emergency contraception. It can be inserted up to 5 days after unprotected sexual intercourse or up to 5 days after the earliest likely day of ovulation, that is, before implantation. The IUD can then be removed with the next period or left in situ for long-term contraception. If you need a fitting, call your GP or any sexual health clinic in your area and say it's for an emergency fitting when making the appointment. If patients prefer oral emergency hormonal contraception, then advice regarding a short window of use, a maximum of 72 hours after unprotected sexual intercourse. They work by delaying ovulation, hence more likely to fail if taken too late in the cycle, especially if there has been inadequate contraception in earlier sexual intercourse than in the index case. Copper IUD can create this inflammatory fluid quicker compared to the hormonal intrauterine system, which is why the former is used in emergency contraception. What are the common side effects of using a contraceptive method? This depends on the type. The barrier methods can cause local irritation and decrease sensitivity, especially for the male using a condom. Progestogenic side effects include depression, sustained weight gain, loss of libido with mood change, acne, hirsutism, vaginal dryness, and breast tenderness. Estrogenic excess can lead to nausea, bloating, breast tenderness, cyclical weight gain, vaginal discharge with no infection, loss of libido with no mood change, benign breast disease, fibroids, and endometriosis. Recent exposure to exogenous estrogen has linked to a small increased risk of breast cancer. The woman's age, family history of breast cancer, smoking history, and obesity are higher risk factors for breast cancer than contraceptive pill use. The intrauterine devices and systems can cause pain and bleeding, but attempts should be made to exclude causes like ectopic pregnancy, miscarriage, malpositioned or perforated device, and pelvic inflammatory disease. I will leave a link to a very resourceful book by Professor Guillebaud and MacGregor. Check the link in the description for details. Finally, let's review how to use the UK medical eligibility criteria for recommending contraception. UK Medical Eligibility Criteria, UKMEC, is a classification system of risk factors and contraindications for all contraceptive methods. It is available as a summary sheet. It shows the significant medical history to consider in the left-hand column and the relevant methods in the row to the right. The 4 UKMEC levels are assigned numbers 1 to 4. In Category 1 and 2, the patient's history does not contraindicate use. In Categories 3 and 4, the patient either needs a specialist opinion before use or is outright not suitable for that patient. You are not expected to commit all this to memory. Routinely go through the list after you have taken a history to make sure no significant condition has been missed. Check that a patient's chosen method doesn't have a 3 or 4 in any of the listed conditions. Also consider in general that where more than one condition applies, the situation is moved up one category, for example, 2 Category 2 conditions. Move the situation to Category 3. The addition of a Category 2 or 3 condition to another category condition moves the situation to Category 4. I hope this helps you with a framework to build your understanding of the use of contraceptives. Thanks for watching. Don't forget to like, share and subscribe to the channel for more educational videos.